Welcome to this video on designing the intensive care unit of the future. We will explore how evidence-based design can transform the ICU bed space from a passive source of patient harm into an active contributor to recovery. While we are saving more lives, the quality of survival often lags due to complications like delirium and sleep deprivation. Surprisingly, the physical environment remains a major, under-recognized contributor, as ICU design has struggled to keep pace with medical advancements. In this video, we build an argument for a better ICU. We will examine the core problems, review the evidence base, analyze a successful case study, and provide a playbook of transferable principles for future design projects. Our first focus is the problem. The very environment designed to save lives can inadvertently cause harm to patients, their families, and the staff who work there every day. Current bed spaces often work against recovery. Patients are exposed to excessive noise, poor lighting, and isolation, which contribute directly to delirium, psychological distress, and long-term impairment, often referred to as post-intensive care syndrome. When we listen to patients, families, and staff, a clear picture emerges. Patients find the environment scary and confronting, families feel distressed, and staff report that these suboptimal conditions negatively impact health, focus, and the quality of care they provide. Sound is a major stressor. Measured noise levels in ICUs routinely break recommended rules. With constant peak events, some rooms are effectively in, quote, jackhammer territory, while traditional curtains fail to provide any meaningful sound insulation. Light management is equally critical for the body clock. Many ICU environments provide constant, flat lighting, leaving patients without the natural signals for day and night. Protecting patients from light at night is essential to support recovery. How did we get here? Many ICU rooms are essentially frozen in the design standards of the 1960s. While medical care has been transformed, the physical shell has not, leaving us with spaces that are no longer fit for purpose. Several root causes explain why this design stagnation occurred, including an awareness gap, risk asymmetry, the tendency to treat healing features as optional extras, and the assumption that retrofitting live units is unfeasible. Moving to the evidence base, decades of research provide a clear path forward. The knowledge to design a healing ICU exists. The challenge lies in our collective will to apply it. Landmark findings confirm that design changes outcomes. From the benefits of nature views and daylight therapy to the significant impact of reducing noise to prevent delirium, the evidence is robust and points toward a patient-centered approach. A successful planning framework organizes the unit into 4 distinct zones: the patient care zone, clinical support, unit support, and family support. This structure helps prioritize direct patient care while effectively managing logistics. Spatial standards are also vital. Guidelines emphasize providing enough space for the bed to, quote, float mid-room with access from all sides, ensuring clinical staff have the room necessary for complex, life-saving procedures. Finally, single rooms are now the default standard, offering improved safety, better infection control, and increased privacy. When planning these spaces, however, we must remain mindful of potential isolation and prioritize connectivity. Moving on to unit configuration, we focus on right sizing. Pods of 8 to 12 beds balance situational awareness with efficient staffing. We also apply a capacity rule of thumb to ensure sufficient bed supply and build in isolation capabilities from the start. Sightlines are a safety system, not a preference. Poor patient visualization is linked to higher mortality. We decentralize nursing to keep them near patients while maintaining central oversight and utilizing glass fronts and readable monitors for enhanced visibility. Daylight is a requirement, not a luxury. A clear day-night distinction at every bed is a key design goal. We prioritize external views, visible clocks for orientation, and durable window treatments that support skin tone assessment. To engineer the soundscape, we set clear targets for lower reverberation times and ambient noise. By using high NRC ceiling systems, absorptive wall panels, and strategic layouts, we create a quieter environment that supports healing. Infection prevention must be built in, not bolted on. This means prioritizing hand hygiene geometry, proper isolation design with anterooms, forgiving surfaces that are easy to clean, and separating clinical systems like dialysis water and drainage. We must design for the family, not just the patient. Providing family lounges, quiet consult rooms, overnight facilities, and nourishment options recognizes their vital role in the patient's recovery journey. Protecting the staff who run the unit is essential. This includes creating restorative spaces with daylight, providing adequate on-call and changing facilities, integrating education and simulation space, and using layout for safety. The technological backbone of the ICU must be robust. We plan for tomorrow by ensuring spare capacity in cabling, integrating remote monitoring, and shifting to wireless-first equipment to declutter the bedside. Now let's look at a practical case study, creating the ICU of the future. This project at the Prince Charles Hospital in Brisbane involved a participatory retrofit of 2 live ICU bed spaces centered entirely around patient needs. This project was a 27-bed tertiary ICU upgrade. The challenge was to rebuild within a live, operating unit. Constraints like windowless rooms became the brief, and every design choice was rigorously tested for its impact on patient outcomes. The methodology followed a 5-stage pathway: define, design, plan, build, and evaluate. By involving stakeholders at every step and using evidence-based frameworks, the project ensured that solutions were truly fit for purpose. In Stage 1, we defined the problems through lived experience, objective measurement, and a literature review. This allowed us to build a robust list of patient-centered problems that served as the project's contract. The resulting problem map set 4 clear aims: reducing environmental stressors, improving the patient experience, enhancing clinical outcomes, and optimizing the bed space itself. These goals guided every subsequent decision. In the co-design stage, we put patients in the room where decisions happened. Through multidisciplinary workshops and iterative cycles, we ensured that the voices of those who know the ICU best were at the center of the design process. Finally, the planning phase involved site investigation, rigorous scoring of ideas, detailed design development, and building a full-scale prototype. By simulating and testing these changes before implementation, we minimized risks in a live clinical environment. Moving to construction, our team successfully built within a live, 27-bed ICU. By isolating work zones and meticulously managing access and noise, we maintained full unit operation. We focused on a true retrofit, integrating with existing infrastructure to create a foundation for future technological upgrades without major structural overhauls. To tackle noise, we introduced sound-absorbing materials. Hard hospital surfaces reflect sound, so we installed fabric-wrapped acoustic panels that meet infection control standards. Coupled with specialized ceiling tiles and flooring, we successfully reduced reverberation, creating a much calmer environment for the patient. Blocking sound was our next step. Traditional curtains offer zero sound insulation, so we converted open bays into single rooms using solid walls and manual partitions with extra thick acoustic glass. This provides essential noise reduction while maintaining the visual connection critical for patient safety. We also rethought the alarm. Historically, monitors screamed from just above the patient's head. By moving the active alarm to the nurse's station and engineering out nuisance alerts, we significantly reduced the noise levels at the patient's ear, effectively halving the perceived loudness. Since these rooms were windowless, we designed a bespoke circadian lighting system. It mimics the natural daily spectrum, morning, noon, sunset, and night, to support the patient's biological clock. Nocturnal settings provide enough light for safe care without disturbing the patient's rest. To address the lack of nature, we utilized virtual windows and artificial skylights. These displays offer dynamic nature scenes and soundscapes that can be personalized to each patient's taste, providing positive distraction while we continue to study their long-term clinical benefits. We also focused on patient engagement and autonomy. An entertainment system allows patients to connect with family via virtual visits and stream personalized audio through speakers built into the bed. This restores a sense of control over their immediate environment. For staff, we decluttered the bedside. A periscope pendant system delivers gases and power only when needed, moving away when not in use. This, along with relocated monitoring and improved nurse call systems, makes the environment safer and more responsive for the entire care team. Our early evaluation shows real success. Reverberation times were more than halved, external sound was blocked, and background noise was significantly lowered. These physical improvements pave the way for the next phase, testing their direct impact on patient sleep, delirium, and long-term recovery. Every project needs a playbook. We have distilled our experiences into a transferable guide. Whether you are building a new facility or retrofitting an old one, these principles apply globally to transform the ICU into a space that truly promotes healing. Our implementation taught us several lessons. Put human factors first, plan for predictable resistance, and accept that retrofit limits are real but surmountable. Amidst mid-project challenges, Co-design remained our strongest tool to achieve meaningful transformation in a complex clinical space. Finally, we must close the loop by evaluating what we build. Measure everything, from lighting and sound to patient and staff outcomes, before the first patient arrives. Most importantly, publish your results so the entire field can learn and advance together. Looking ahead, the future of ICU design is moving toward smart ICUs with unified data, ICUs without walls that provide remote oversight, and acuity-adaptable rooms. The core thread is future-proofing, building flexible spaces that can evolve alongside medical technology. In summary, our 10 principles emphasize co-design, sufficient space, sightlines, daylight, engineered acoustics, smarter alarms, nature-based distraction, family support, infection control, and future-ready infrastructure. Always calibrate these principles to your local culture and clinical environment. Design is a dose. Treat the ICU room as a critical medical treatment, prescribed with as much care as any drug. Use evidence, engage your end users, and continue to measure and publish. Be the evidence our healthcare systems need.